Good evening, and welcome to tonight's CardioCore Lecture series. I'm David Marin, Professor of Medicine at Stanford University. I'm pleased to introduce tonight's speaker, Dr. Charles German. Dr. German is Assistant Professor of Medicine and Director of Preventive Cardiology at Georgetown University in Washington, D.C. He completed medical school at the University of Texas Medical Branch at Galveston, internal medicine training at the University of Alabama, and at Wake Forest, he completed a T32, a master's degree in clinical and population translational sciences, a cardiology fellowship, and a dedicated year of preventive cardiology training. Dr. German's research focuses on physical activity, cardiometabolic disease, and subclinical atherosclerosis using large epidemiologic cohort studies. His work has been published in top-tier journals, including JAMA, JACC, and Hypertension. The title of his talk is The Role of Physical Activity in Cardiovascular Health and Prevention of Cardiovascular Disease. Welcome, Dr. German.
Thank you, Dr. Marin, for that kind introduction, and thank you to the ASPC for having me today. I am here to talk about my favorite topic, which is the role of physical activity in cardiovascular health and the prevention of cardiovascular disease. I have no disclosures. So here's our outline for today. We'll start by talking about the burden of physical activity. Then we'll get into the physical activity guidelines, highlighting not only the US physical activity guidelines, but also the Canadian guidelines. We will discuss exercise intensity as well as resistance training, which has become particularly important in the era of anti-obesity medications and their effects on cardiovascular disease outcomes. Next, we'll delve into steps and then talk about the pattern of physical activity accumulation, meaning does it matter if you get more of your exercise on the weekends, which is termed the weekend warrior, and versus more equal distribution over the course of a week? Does that matter? And then we'll talk about lifestyle behaviors, and we'll discuss the 5 A's model, which is a validated tool of lifestyle behavior change that works not only for encouraging physical activity, but really for all lifestyles, modifications that may need to be changed. And then we'll end by talking about exercise prescriptions, hopefully something that you can utilize in your clinic with all of your patients. So this is the problem. This is the global rate of physical inactivity, which right now is roughly about 32% of the population. Unfortunately, this is increasing and has been increasing over the last several years. And it looks like by roughly 2030, the global rate of physical inactivity will reach 35%. And notably, physical activity, at least for the purposes of this graph and for most of the literature, really means not reaching the physical activity guideline. And as you can see here, there is differences based off of what part of the globe that you live in. So what does this look like on more of a local scale? This is data from the CDC. On the left-hand side here, we have the prevalence of physical activity broken down by age as well as sex. And so the lighter bars are males, the darker bars are females. And if you look at the top section, this is physical activity for adolescents 11 to 17. And I think this is really striking. If you look at the light bar, the males, 64% are physically inactive, females, 81% are physically inactive. Once you reach adulthood, that's the middle section here, this is 18 plus, 32% of males, 48% of females are physically inactive. And then it gets a little bit worse as you age. This is 70 plus, 47% males and 65% females are physically inactive. So really striking statistics here. And then if you look in the middle, this is from the BRFSS, that's the Behavioral Risk Factor Surveillance Survey, also from the CDC, and you see the distribution here by state level, where the darker states represent higher rates of physical inactivity. And this is really what I think you would expect, which is that the Deep South has the highest rates of physical activity, inactivity, excuse me, and then it gets a little bit better more in the Midwest, and then maybe the Northwest, and then Vermont there. has pretty low rates. And then this is another graph that comes from the Global Burden of Disease study. This is from 2024, and specifically this is for the United States. And this is looking at deaths due to low physical activity, which is striking. Again, as of 2021, over 30,000 deaths are attributable to low physical activity. And as you can see over time, this graph is worsening, the trend is worsening. So deaths due to low activity are on the rise. So certainly this is something that we need to do better about our population level. So what's the solution? This is a quote from Tom Friedman, who's one of the former directors of the CDC. And I really like this. He says that physical activity is the closest thing that we have to a wonder drug. So what does he mean by that? Well, it's accessible to everybody. You don't have to have money to engage in physical activity. It's not a pill that you have to pay for. It's cheap. In fact, it's free. It's extremely effective. It has a multitude of benefits, both cardiovascular and non-cardiovascular, that we'll delve into. And it sort of helps everything, including multiple different types of cancers. So what are the cardiovascular benefits of regular physical activity? I'm not going to belabor this. I think many on the audience probably know that physical activity really benefits the heart in a multitude of ways. There are anti-atherosclerotic properties, anti-arrhythmic properties, anti-thrombotic properties, ischemic properties. And then on the left-hand side here, psychological health. There's benefits as far as decreasing depression, anxiety, stress, and maybe even improving cognitive function. Specifically, this is with regards to aerobic activity, although there are similar benefits with regards to anaerobic or muscle strengthening exercises that we will touch on here in a little bit. All right, so this is the physical activity guideline. This is actually the second iteration of the guideline. It came out in 2018. We're hoping for another update here soon. And the left-hand side is really the bulk. This is sort of the major take-home from the guideline, which is that for overarching health, you should achieve at least, and I want to stress the word at least, 150 minutes of moderate intensity physical activity. And in addition to that, 2 days of muscle strengthening exercises. And so on the right-hand side, they go into a little bit more detail. Really, it's 150 to 300 minutes of moderate intensity, or 75 to 150 minutes of vigorous intensity physical activity, or some sort of combination of the two for overarching health. And they talk a little bit more on the muscle strengthening on the pictorial on the bottom, with a focus on hitting all major muscle groups on 2 or more days a week for additional benefits above and beyond just the aerobic benefits. This is the Canadian guideline that came out a couple years later. This is from 2020. And I think this is really nice, and this is the way I hope that the US guidelines will go. This is more of a behavior movement guideline. So focusing on not only physical activity, but also the other things that occur in a 24-hour day. So they also give recommendations on sleep as well as sedentary behavior. And they break down activity into both light as well as moderate to vigorous physical activity. And I think this is really important and something that they don't teach us in medical school, which is that even light intensity physical activity, and we'll look at the data here shortly, you get major benefits if you're sedentary. So if your comparator group is a largely sedentary person, or if you're seeing a patient that's largely sedentary, they don't have to go run a mile. They don't have to go to the gym. Just getting out and doing light intensity activities can have major benefits for that individual. So the exercise component is roughly the same as the US guideline. For sleep, they recommend getting 7 to 9 hours of good quality sleep. The relationship with sleep in cardiovascular disease and mortality is U-shaped. There's sort of a magic number of somewhere around 6 to 7 to 9. and you get less benefit and potential harm getting less than 6 hours or 7 hours and more than 9 hours. So there's a sweet spot, it's about 7 to 9. And then obviously you want to limit the amount of sedentary behavior. And in this particular guideline, they recommend limiting sedentary time to 8 hours or less over a 24-hour period. So that's sort of the clinical guideline on the left-hand side. On the right-hand side is more of a research tool, but it really has the same sort of ethos as the Canadian guideline. A lot of the literature thus far has looked at these behaviors sort of singularly in their relationship with cardiovascular disease outcomes. And you really can't look at these in isolation because they're all entangled. If you're sleeping, you're not exercising, but if, let's say, you wake up to go to the gym in the morning, you're decreasing your sleeping time, but you're increasing your activity time. So all of these health behaviors influence one another. For the researchers out there, for people like me, and this is something that really got me interested in the field many years ago, is really looking at these different components of behaviors, health behaviors, activities at the same time, and their relationship with outcomes. Next up here, we have my favorite slide and really my favorite study from the 2018 US guideline. And this was a systematic review and meta-analysis of 13 studies that looked at the relationship between sitting time, exercise, and then all-cause mortality. So on the bottom of this graph here, you have 4 different categories of exercise volume. On the far left-hand side, you have greater than 35.5 met hours per week. So that's a high activity group. And that roughly is about 60 to 75 minutes of activity a day. And then within that group, you have various times of sitting or sitting time. And so really the message, the take-home point here, which I think is pretty interesting, is that if you're getting a high amount of physical activity, but you're sitting greater than 8 hours a day versus not sitting a lot, less than 4 hours a day, your hazard ratio for mortality is roughly the same. So really what that says is that even if you sit for long periods of time, you can offset the negative effects of that sitting with a lot of activity, which I think is particularly encouraging for patients as well as myself in a largely sedentary job when I'm in clinic. So next up, this is physical activity intensity. And this is important because the guidelines are written in intensity. So you have to know what this means so that you can talk about this with your patients. So intensity is, this is the absolute intensity, is the rate of energy expenditure required to perform any physical activity. It can be measured in many different ways, including METs, kilocalories, joules, or oxygen consumption. That's obtained from a CPET or CPEX. 1 MET is equal to the rate of energy expenditure while at rest, which is equal to an oxygen uptake of 3.5 milliliters per kilogram per minute. And then there are MET categories of intensity. So these are sort of rough estimates. Sedentary behavior is considered less than or equal to 1.5 METs. Light intensity physical activity is 1.6 to 2.9. Moderate intensity is 3 to 5.9, and then vigorous intensity physical activity is 6 or more METs. So again, you got to be able to translate this to your patients because remember, it's 150 minutes of moderate or 75 minutes of vigorous. So what does that actually mean? So the guidelines give you 2 different ways to communicate this information. The first one is the sing-talk test. So light intensity activity would be where you could sing. Vigorous intensity would be where you can only speak a few words, and moderate would be somewhere in the middle where you could talk but not sing. So that's one way to describe it to your patients. The other is like a Likert scale or a Borg, for example, a rate of perceived exertion, that's the RPE. And that's really a patient-centered sort of subjective measure where light is considered somewhere from a 3 to a 4, moderate would be a 5 to a 6, and vigorous would be 7 or more. And then on the right-hand side here, we have just examples of activities that are roughly equivalent to either moderate or vigorous intensity physical activity. So we have things like walking, mowing the lawn, badminton, funny enough, tennis doubles versus singles. Singles they consider as vigorous versus doubles as moderate. Of course, this is all individualized to the particular person. All right, this is the resistance training AHA scientific statement. This came out a few years ago. A really excellent writing group, and I think this is really timely. You'll notice Barry Franklin, one of our esteemed members of the ASPC, was a part of the guideline committee or the scientific statement committee for this. So resistance training is exercise that evokes muscular contraction against an external force. Adults who participate in resistance training have about a 15% lower risk of all-cause mortality and a 75% lower risk of cardiovascular disease. And this is compared to adults that don't do any resistance training. So this is important. How good is the population at doing this? Well, not good. Only 28% of the U.S. Adults report participating in the guideline recommended 2 days per week of resistance training. So we need to do better. So a couple of graphs here, tables that I wanted to highlight. This is the association of resistance training with non-traditional cardiovascular risk factors. So I'm just going to highlight a few of these here. First up is cardiorespiratory fitness. CRF or cardiorespiratory fitness is potentially our strongest marker of health and cardiovascular health. And so resistance training seems to improve your peak VO2 similarly to aerobic training, 17% versus 21%. So that's really, really remarkable. There may be benefits as well on inflammation. There's been a few studies that show reductions in CRP. There's also improvements in endothelial function with some studies looking at flow-mediated dilation. Just like the aerobic component, there are improvements in mood with depression and anxiety improving. There's benefits from a quality of life perspective. There are positive benefits with both mental health as well as physical health related quality of life. And then sleep. Remember, these behaviors are all entangled with one another, with maybe the strongest benefit with regard to the quality of sleep as opposed to, say, the quantity of sleep. So what about traditional cardiovascular disease risk factors? I'm just going to focus on a few of these here. If you look at the magnitude of benefit portion of this table, on the left-hand side, the little man doing the weights, that represents obviously resistance training. The running man represents aerobic activity, and then on the right is combination of the two. And so you really get pretty good bang for your buck with glycemic control, particularly with combination aerobic and resistance training. Improvements in hemoglobin A1C, and then the body composition at the very bottom here. This is looking at both lean and fat mass. So when you combine the two, aerobic as well as resistance training, you get beneficial effects with preservation of lean mass and then loss of fat mass. Again, this is the combination of the two. And going back to what I said earlier in this talk, a big component of preventive cardiology, cardiometabolic health, the obesity epidemic, diabetes, GLP-1 receptor agonists. Of course, we don't have the data just yet, but this is why we suggest or we recommend resistance training, muscle strengthening exercises as you lose weight on these medications. And that's because when you do lose weight, really regardless of the mechanism, in particular with these drugs, we've seen that roughly 2/3 of that weight loss is fat mass, but 1/3 of that weight loss is muscle mass. And so obviously that's not good. You don't want to lose muscle mass. So this is some extrapolation here, but the recommendation is always to make sure that for patients that are on these medications, that you're increasing their resistance training, their muscle strengthening exercises, with the idea that hopefully you'll be preserving their lean mass while preferentially losing that fat mass. All right, next, let's talk about steps. So we all know that the magic number is 10,000 steps per day, but that magic number actually did not come from science. It didn't come from data. It's actually a really interesting story. So in 1964, Tokyo hosted the Olympics. And around that time, there was a pedometer that came out, and the pedometer company hired a marketing company, and the marketing company actually created that magic 10,000 steps per day number. It was totally a marketing gig. And the name of the pedometer was Man-po-K. And Man-po-K literally translates to 10,000 steps meter. And if you look at this little picture on the bottom here, some people think that the Japanese character actually looks like a walking man or a running man. So that magic number comes from the 60s. It was not based in science or literature or data, but obviously that company did a great job, because that has really stuck in the vernacular for decades. So really the question is it right? Turns out it's actually pretty accurate. This is, I think, one of the earliest, more contemporary studies looking at the association of steps, both step count and intensity, with mortality. This was a study done by Pedro St. Maurice out of the NIH in 2020. This is data from NHANES. And you see this really beautiful classic dose response curve that we've seen in the majority of the literature, which is to say that the more steps per day that you do, the more mortality benefit that you gain. And if you look at where that graph sort of naters, it's right around 10,000 steps. So it turns out that that magic 10,000 steps per day was actually pretty accurate. So a little bit more from this particular study. They looked at differences by both sex and age. And as you can see by the shapes of these curves here, again, steps per day at the bottom, mortality on the y-axis, it differs. So men and women, they both gain a major benefit going from not a lot of steps per day, let's say around 2,000, to just a modest amount, 6,000 to 8,000 steps per day. So you get that rapid benefit going from low activity to sort of a moderate amount of activity. And then there's sort of diminishing returns the further out you go on the graphs. And so it looks like for any given dose of steps, women seem to derive a little bit more mortality benefit compared to men. That's on the left-hand side. On the right-hand side, if you look at mortality rates by age, you see that for the older individuals greater than 65, they seem to derive the most benefit compared to the younger individuals, 40 to 49. And you'll see also what you can glean from these graphs are that the older folks don't need as much activity compared to the younger folks to derive the same benefit. So a lot of studies have been done looking at these associations. This was a very nice one that came out from Amanda Paluch, Circulation 2022. This was a harmonized meta-analysis, and these are cubic splines broken down by age, greater than 60 on the left-hand side and less than 60 on the right-hand side, to see really where do you gain the most benefit. And what they found is that you may not actually need 10,000 steps per day to sort of get the maximal benefit. So on the left-hand side here, if you look at older adults greater than or equal to 60, somewhere around 6,000 to 9,000 steps per day is maybe where you gain a lot of the benefit. And that's you get about a 50% lower mortality risk compared to those that do about 2,000 steps per day. If you look on the right-hand side for younger adults less than 60, you get most of the benefit around 8,000 or 9,000 steps per day, with sort of diminishing benefit as you keep going. So it may be that you actually don't need that 10,000 steps per day. If you move along here, this was steps and all-cause mortality, same data set from Amanda Paluch, also broken down by age, less than 60 in the red and greater than or equal to 60 in the blue. And you see here that basically for those that are 60 years and older, increasing steps until about 6,000 to 8,000 is where you get the maximal benefit. And for those that are younger than 60, the maximal benefit is somewhere around 8,000 to 10,000 steps per day. So again, we're seeing differences not only by sex, but also by age. So you may not actually need that 10,000 steps per day, particularly if you're older than 60 or 65. You only need about 8 to maybe 10,000 steps. Next up here, this is another study that looked at the stepping cadence. Stepping cadence is basically the intensity of steps. How quickly are you taking those steps? Does that matter? Or is it just the volume, the amount of steps you're taking? So on the top, we're looking at intermediate cadence versus low stepping cadence, basically slow walking versus sort of an intermediate rate of walking. And you see that there is benefit for intermediate rates of walking. And then you look at the bottom one, high rates of walking or fast walking versus slower walking. And again, there's benefits for faster walking. And importantly, both of these studies are controlling for the volume, meaning steps per day. So basically what this tells you is that even controlling for volume, the cadence, the intensity of those steps, the speed seems to matter. And you get additional benefit with taking those steps at a faster pace. So next up is the weekend warrior phenomenon. This is encouraging for people like me who are relatively sedentary during the week but have more time and do more of the exercise on the weekends. And so with this particular study, this is N. Haynes, accelerometer-derived objective physical activity, looking at how many days of the week do you achieve 8,000 steps per day. And so obviously your rates of all-cause mortality and cardiovascular disease mortality are high if you don't achieve that on any day. But I think more importantly, look at 1 to 2 days versus 3 to 7 days, roughly similar. So really what this study I think tells you is that you may not actually need to get 8,000 steps per day on every single day. Maybe you can just do it on a couple days a week, which again, I think is encouraging for many patients. They may find it challenging to get in those steps every single day. Well, that was steps. What about MBPA? MBPA, again, is a little bit more validated in the physical activity literature. That's moderate to vigorous physical activity. And there's a lot going on here, so I don't necessarily want to belabor this, but if we look, for example, just focusing on B, on the top right-hand side, this is WW means weekend warrior. That means achieving most of your steps or MBPA over 1 to 2 days versus regular activity, which is more of a spread throughout the week versus inactive. And really what you see here with every single outcome that they looked at, AFib, myocardial infarction, heart failure, and stroke, the hazard ratio, the reduction in these various cardiovascular outcomes are roughly similar if you compare the weekend warrior phenotype to sort of the regular throughout the week activity phenotype. So this mirrors, I think, the STEPS literature. All right, so how do you sort of translate this in clinic? Behavior change is obviously extremely difficult. It doesn't matter what the data is or what the literature is if you can't get the patient to comply or sort of to take in what you're saying. And so this is a validated tool. This is the 5 A's tool that is helpful for lifestyle-related behavior change counseling, which is something that you can do in your clinical practice. So the first A is assess, and then you advise, you agree to a SMART goal. SMART stands for a specific, measurable, achievable, realistic, and timed goal for behavior change. You assist them with identifying solutions and action steps to address these barriers to behavior change. And these may be specific to your location and then of course specific to your patient. And then arranging follow-up. You gotta follow them up, see how they're doing. You gotta meet them where they are. And this tool, again, is beneficial not only for physical activity, behavior change, but really for all sort of maladaptive behaviors. This works for behavior counseling with regards to diet, smoking cessation, for sleep, for psychological well-being. So remember, the 5 A's model is a useful tool. So we're nearing the end here. This is aerobic activity guidelines. These are the recommendations, and this is a tool that you can use for your patients. What I want you to remember is FIT. FIT is a mnemonic that stands for frequency, intensity, time, and type. So with regards to frequency, and this comes from the American College of Sports Medicine, generally you can recommend 3 days a week, although remember, maybe only 2 days a week is all you need, as opposed to every single day of the week or 3 days a week. They consider a spread of physical activity. Again, timing is less important. With regards to intensity, 40 to 59% of the heart rate reserve, and we'll go into that. That would equal moderate, or vigorous would be 60 to 89% of your heart rate reserve intensity is recommended for most adults. The time, how many minutes per day? So ACSM recommends about 30 to 60 minutes per day of moderate, or 20 to 60 minutes per day of vigorous intensity activity, which approximates the guidelines or some sort of combination of the two. And then the type. This is a question that comes up all the time. What's the best type of physical activity? Well, the best type of physical activity is the one that the patient is going to do over the long period of time. Like any exposure in preventive cardiology, it only matters if you do it. So I don't necessarily harp on you should be doing this, that, or the other exercise. It's whatever the patient enjoys, because you can't force them to do an activity that they're not going to enjoy. So it's really whatever the patient likes. So prescribing exercise intensity, HRR again stands for the heart rate reserve, and you can see the equation here. We also have the VO2 max, and then the heart rate target, heart rate max at the very bottom there. You know, the heart rate reserve is one that many guys, and it's not terribly accurate, however, but I'll tell you for me, I don't harp too much on the details. I remember the heart rate max, which is the one at the bottom, which is 220 minus age. Again, it's maybe not the most validated one, but it's the one that I remember, and it's sort of close enough, I think, for most folks. If you really want to get into the nitty-gritty, the American College of Sports Medicine does offer several other validated equations that are maybe a little bit better than that 220 minus age. So these are things that you can utilize in your clinical practice if you choose so. What about the resistance training prescription? This also comes from that resistance training guideline that I mentioned, came out in CIRC in 2024. And so if we just focus on the moderate intensity group here, we have 40 to 60% of your 1 rep max. That's the maximum amount that you can do with 1 repetition of weights. The number of reps for moderate intensity is about 8 to 12. Frequency per week, at least 2 days per week. And the muscle adaptation here is both strength and endurance, and this is the recommendation for the general population. Lower intensity on the top, that would be sort of a lower 1 rep max, higher reps. There, the focus is more on endurance, and that's generally for folks that are higher risk. And for the folks that are lower risk, they can do more high intensity resistance training, and that's where you do a higher rate of your 1 rep max, maybe 80% or more, lower reps. So this is sort of lower reps, higher weight. And this, the muscle adaptation here is more for strength. So if you're lazy like me, you can use this printout. This comes from the American College of Sports Medicine. And this is a physical prescription, just like you would prescribe a medication. Actually pretty good data that actually prescribing physical activity with a paper script is a powerful tool for behavior change, and something that the patient will more likely take up, as opposed to just saying you should do X, Y, or Z. This follows the FITT model that we previously discussed, the frequency, intensity, time, and type. So you can really personalize this for the patient that you're seeing in clinic. They also have an area for steps per day if the chosen metric is steps. And generally, I go off of what the patient tells me. I use open-ended questions when assessing their physical activity. And if they tell me that they do X, Y, or Z steps, then maybe we'll use a step-related goal as opposed to, say, a moderate to vigorous physical activity. And lastly, we can't forget about our friend cardiac rehab for secondary prevention. Cardiac rehab has been around for a long time. This is for patients with established cardiovascular disease. We do a really terrible job at referring patients for cardiac rehab. Remember, it's a class 1 indication in a multitude of both national and international guidelines. And cardiac rehab is more than just an exercise program. It's really a comprehensive program, multidisciplinary. A lot of programs have dietary counseling, counseling on risk factor control, that is diabetes management, dyslipidemia, blood pressure, smoking cessation, body weight management, psychological health and well-being. And now cardiac rehabs are being delivered in new ways since the COVID era. These are not just center-based programs. We now have remote programs, virtual programs, a lot more encouraging data that these programs are actually safe and effective. So don't forget about cardiac rehab for your patients that have existing cardiovascular disease that meet the indication. So in conclusion, a few take-home points. The majority of US adults are considered physically inactive. We're doing a bad job and we need to do better. And the deaths attributable to physical activity are unacceptably high. However, this is a tool that all of us can do, all patients can do it. It's cheap, it's effective, it's safe. Guideline recommendations are at least 150 to 300 minutes of moderate, or at least 75 to 150 minutes of vigorous intensity physical activity per week, or a combination of the two for global health and cardiovascular benefits. The guidelines recommend at least 2 days per week of muscle strengthening exercises. And again, the Canadian guidelines go one step further. They talk about sleep duration, somewhere around 7 to 9 hours of sleep for maximal benefit, and reducing your sedentary time, and less is better here. Don't forget about resistance training, which provides a wide-ranging benefit of both cardiovascular and non-cardiovascular risk factors, greatly beneficial. And this is on top of aerobic activity. And those benefits are larger, and these are usually complementary. With regards to the amount of steps per day, most folks actually don't need 10,000 steps per day. And it looks like it depends on your age. If you're less than 60, the mortality benefit levels around 8 to 10,000 steps per day. But if you're older than 60, you don't need that much. Around 6 to 8,000 steps per day may be enough. Don't forget about the 5 A's of behavior change, which is a validated tool to promote and engage physical activity for your patients. And the exercise prescription, FIT, frequency, intensity, time, and type. So with that, I thank you for your attention, and I look forward to an engaging discussion. Thanks for having me.
Charles, thanks for an excellent presentation and a really practical one on physical activity. I want to encourage those of you in the audience to submit questions if you have them. Of course, I got a ton of them for Dr. German, but you should be able to see on the right-hand side of your viewer a place to submit questions if you'd like. So to start with, Charles, what accounts, from your perspective, why do you think there's such geographic differences in physical activity? The South was quite red.
Yeah.
What do you think accounts for that?
Yeah, that's a great question. And I also just want to say thank you again, David, and thank you to the ASPC for having me. Major geographic differences, absolutely. And there's a lot that I think goes into that. One of the concepts that I think about is the idea of the built environment. So the built environment is basically you have to live in an environment that is makes it easy to engage in physical activity. And so more compact, larger cities, let's say cities like New York City, or LA, people take the subway, people walk everywhere. They don't necessarily drive. But in the Deep South, where you have a lot more space, there's a lot more driving, there's less physical activity. Maybe the environment you live in has no sidewalks, for example, or maybe there's no lights at nighttime, so it makes it much more challenging. Of course, there's also the differences in risk factors as well. A lot more obesity in the Deep South. So there's a lot that goes into it. And just a quick anecdote too. I'll never forget this. The first time I started my job in Chicago, working in the South Side predominantly, I always talk to my patients, of course, about physical activity. And I asked, do they walk around the neighborhood? And they told me that, doc, I'm afraid of getting shot if I walk outside. And that really hit hard. And so this idea of having an environment that is safe to walk in is really critical, with the differences across the spectrum. So it's critical.
So you mentioned obesity in the South. How much of that obesity is due to physical inactivity or other factors?
Yeah, that's also a great question, and difficult to parse out. The contribution of physical activity to weight, it's very important. Of course, the backbone, the tenets of prevention and weight management is lifestyle, and part of that is physical activity. But honestly, the answer too is that for folks that have or patients with overweight or obesity, physical activity in and of itself is not going to decrease the weight, which is the truth. It's one component. It's important for cardiovascular health, but oftentimes the diet needs to change as well. And so it's a contribution, just like it is for many things, but it's not sort of the driver, I would say.
We have a comment or a request. Please comment on self-reported activity versus measured fitness, such as VO2 max, as relative indicators of activity.
Absolutely. Yeah. So,
as reliable indicators of activity.
I see. Yeah. So, the older physical activity literature from the large population cohort studies were all self-report. And I think we all know, talking to our patients, if you ask how much did you exercise last week, they're going to say, oh, I ran a mile, I ran 10 miles, when that may not actually be true. So more contemporaneously, the studies now are using objective measures like accelerometers. And of course now, not everybody necessarily has an accelerometer, but we all have smartwatches and iPhones and things that track our steps. Those are objective. You can't fudge those sorts of things. So those are much more reliable indicators. Now, when it comes to things like fitness, our gold standard is a peak VO2, which is obtained from a cardiopulmonary exercise stress test, but not everybody has that test done, nor is it really indicated. An iPhone, for example, will give you an estimated peak VO2, but that is very coarse. The data from that actually comes from the FRIEND registry, which is a registry some of my colleagues have helped develop, but it's sort of really wide confidence interval is not that accurate. But I do think that the steps measure for most regular ambulatory movement is quite accurate for people.
Great. Now there's another comment, and I'm sorry, it's a little blurry for me, so I'm having a little trouble reading it, but it says, thanks, Charles. We know that referral to cardiac rehab is poor, but we also have issues with enrollment following referral and delays in enrollment. Why do you think this is?
Yeah, that's a toughie. Absolutely, cardiac rehab should have a very low threshold for referrals for those that have the indication. As far as the issues with enrollment following referral, there's a myriad of reasons. It may be that something that I learned when I was the director of cardiac rehab at my prior institution, there's actually a copay for this. It's not technically free. So sometimes that's a barrier. It may be that it's difficult for people to get to cardiac rehab. It's far, it's not convenient. It's 3 times a week generally in the middle of the day. People have jobs. It's hard to get to cardiac rehab 3 times a day. So there's massive barriers to this great class 1 indication. But I think the field is moving towards more of a hybrid or even an at-home types of cardiac rehab. We need a little bit more data, I think, but all of the early literature suggests that it's at least as effective as the congenial hospital-based cardiac rehab. So these are things that you can utilize for your patients if you have those resources available at your institution.
Good. Now, here's another one from our audience. Where does data from the friend registry, sorry, it's really hard to read. Where does it come from? Where does data from the friend registry come from? Is it reflective of our entire population, or are there populations not represented?
Yeah, that's a very specific question. So the friend registry was started out of Ball State. Lenny Kaminsky, who's a mentor, actually helped lead this registry. And it's all comers. It's not a diseased population. It's not necessarily a totally healthy population, but that registry encompasses people from multiple institutions. So it's supposed to be representative of our country and our nation's sort of congenial health. So it's some of the best data I think we have for all comers, but it's not necessarily specific to people with existing cardiovascular disease. But it's pretty good.
Is there a time of day when it's best to exercise from a physiological perspective?
Yeah, that's an active area of research, David. It's a great question. It's actually something that I'm keenly interested in. In order to really answer that question well, you should probably have accelerometry, 24-hour accelerometry. And I've seen this done where you look at people that predominantly exercise in the morning versus afternoon versus at night, and it's all over the map. There's no consistency from what I can tell. My thought there is that I think it has to do with that person's chronotrope. And the chronotrope is the idea that are you a morning person or a night person? And so if you can pattern your activity based off of the individual's chronotype, that may be the optimal time for that person, but it's different, I think, for each individual.
Is the increased risk from the time spent sitting due to reduced time being physically active, or is it specifically due to an adverse effect from sitting?
Can you say that one more time?
Well, the question is, being inactive has bad consequences, and particularly sedentary time.
Right.
Is sedentary time just the inverse of being physically active, or is there something specifically injurious from spending a lot of time being sedentary?
Yeah, that's a great question, and I don't know that we know the answer to that specifically. I think you need to know the mechanism there, and to be quite honest, we don't know the entire mechanism of how physical activity leads to health benefits. The MotorPack study is trying to delineate that, which is ongoing. But there seems to be effects outside of just not being active, for example, that makes sedentary time deleterious. But, something that I particularly like in one of the slides that I showed was that if you look at sort of larger data sets, if you're very sedentary, if you're very active outside of that very sedentary time, it can sort of offset those effects. So this is sort of also the concept of the weekend warrior. If you have a very sedentary job and you're sitting, but you really get after it on the weekends, you may be able to offset the negative effects of that sedentary time.
I think that's reassuring for a lot of us. Can you provide more detail about guidelines for resistance training? I mean, I wonder, are the guidelines as specific about the time that one should spend doing resistance training and which muscle groups you should use, what types of exercise? Is there more detail? Because it's becoming clear that resistance training is important. We've been talking so much about aerobic activity for so many years. What guidance do you have?
Yeah, no, I totally agree. The resistance training part often goes by the wayside, and the focus is always on the aerobic activity. There's still a lot to be learned, I think, about the really nitty-gritty details about resistance training. What we do know is that in the congenial recommendation is 2 days a week, all muscle groups, and trying to rotate the two. And then, the recommendation should be dependent upon the patient's level of risk. So for lower risk individuals, it's okay to recommend higher weight training, more heavyweight sort of resistance training. And then the vice versa for those patients that are higher risk. You may not want them lifting heavy weights. You may want to do lower weight, higher repetition exercises, which lends more towards the endurance.
So what constitutes a high-risk patient for resistance training? I mean, I always tell a patient that has, for example, an aortic aneurysm that we're monitoring to avoid doing, heavy weightlifting. What constitutes a high risk, or when is it not safe for somebody to do resistance exercise?
Yeah. So I think the sort of obvious things are, high risk arrhythmias, history of VT, for example, obstructive diseases like hypertrophic cardiomyopathy being one of them. Decompensation of any sort of cardiovascular disease would not be a good idea. But to be honest with you, there's sort of few and far in between, in my opinion. And I think patients are particularly scared and afraid after they've had an event. But even in higher risk populations, or what we used to consider high risk, the needle is moving towards safety. And to give one example, this is not necessarily in the preventive cardiology space, but in hypertrophic cardiomyopathy, we used to sort of say patients shouldn't do high intensity exercises like muscle strengthening exercises, for example, because of the concern that you're going to worsen that obstruction and precipitate sudden cardiac death or VT, for example. That's changed. The most recent guidelines, they're much less restrictive, and it's a lot more about shared decision making. And most of the literature says that it's actually okay for some of these higher risk conditions to do muscle strengthening exercises.
So is high intensity physical activity better for you than moderate intensity physical activity?
Yeah. Well, the way the guidelines are written, it's either or it's a combination, some sort of combination of the two. And so right now, the congenial logic is that it doesn't matter how you parse it out, meaning if you do some moderate intensity on day one, you do some vigorous on day two, it's more about the cumulative amount you get over the course of a period of time. The more the better, generally speaking, the more the better. The more intensity or the higher intensity, the more that's going to affect your cardiorespiratory fitness, which is good, which is our best prognostic marker. But there also seems to be a plateau effect as well. And so after you reach a certain point, more may be better, but that benefit, that additional benefit may be very modest and maybe not that meaningful.
So you have a patient who's really sedentary, and somehow you've persuaded them to start an exercise program. Should they have an exercise test before they start doing exercise?
Yeah. I don't think that's necessarily needed unless they're symptomatic. Certainly, if they have concerning cardiac symptoms, that's very reasonable to do an exercise stress test. There is slightly different concept in the sports cardiology world, which is sort of clearance, sort of return, sort of idea of return to play. And there's some very loose guidance and probably more expert consensus that for some of these people, a stress test in the absence of symptoms may be warranted, but I'm not sure of the utility of that personally. But I think if you do have concerning symptoms, which may be shortness of breath, it may be dyspnea on exertion, potentially as an anginal equivalent, I think that's reasonable in that situation.
So, Mary, and I'm sorry, I really can't make out your last name. It's too blurry, but she asks, is there a threshold where more physical activity is not better?
Yeah, Mary's spot on. She's an excellent physical activity researcher. So, if you read the guideline with a fine-tooth comb, you will see that it says more is better and that there's no threshold. But there's actually a few different lines of literature now that suggest that there may be a point where there's no longer benefit and potentially you start to see some harm. And probably the best literature there is in the calcium space. So there's several studies now that have shown that for some of these high endurance athletes, masters athletes that have been exercising at high intensities for decades, develop plaque. And they have no congenial risk factors. So the thought is that there may be some threshold where high intensity over a long enough time leads to the development of plaque and thus subclinical coronary disease. Also, AFib is relatively well known in that there seems to be some sort of threshold there. The last is there's been some cardiac MRI studies showing fibrosis in these athletes as well. And then we all know about the athlete's heart, sort of the adaptations to physical activity. So there does seem to be a threshold effect. There may be a threshold where there starts to be more harm than good. I don't know what that threshold is. I think that's yet to be determined, but it's a very interesting space. I will say, though, that for those high-intensity athletes that do have a lot of coronary calcium and no congenial risk factors, I do think those patients should be treated just like normal calcium. I think they warrant statin therapy. The risk is there regardless of the mechanism. So I think that's important.
And Mary writes, super interesting. Okay, lightning round. We're nearing the end of our time. How important is monitoring heart rate?
Yeah, are you getting at heart rate variability?
No, heart rate during exercise.
Gotcha. Yeah. There are some fitness centers and they use things like zone 1, zone 2, zone 3. It can be useful to motivate people, I think. I don't put too much credence into the max heart rate unless there's a change. I think it may be more important than the absolute heart rate max, for example, is a change in that person's exercise capacity, and everybody knows their body best. So if I have someone that's an athlete and they say, my heart rate's not getting up as much as it used to because I get short of breath more quickly, that's important to know. In an athlete, that may be the manifestation of coronary disease. So it's something to I think personalize for the individual.
Okay, thank you. And we've come to the end of our time. And I want to thank you again for a great presentation and an excellent discussion. And I want to thank those who joined this session and wish you all a good evening. So thanks very much.
Thank you, David.